All right, so we're continuing on with chapter 31, talking about dislocations now. So, a dislocation is that in which a joint, when the bone ends are no longer in contact, supporting ligaments are often torn, usually completely if it's bad enough, which allow those bone ends to completely separate from each other. You can sometimes get a fracture dislocation in combination. Sometimes the dislocated joint will spontaneously reduce, meaning that it will return to its normal position before we even get there. We can only confirm that it was a dislocation based on what the patient tells us. If it doesn't reduce, then we need to transport. Commonly dislocated joints include fingers, shoulders, elbows, and knees. Signs of a dislocation. So, deformity, swelling, pain that's definitely made worse by any movement, tenderness on palpation, virtually complete loss of all normal joint motion. So, you'd have a locked joint. And then numbness or impaired circulation to the limb or digit. We need to often check pulses continuously just to make sure that any movement that we do of that dislocation doesn't cause disruption to blood flow. Sprains. Sprains occur when a joint is twisted or stretched beyond its normal range of motion. You end up getting a result to not only the ligaments, but also the supporting capsule. It can go from either stretched to torn. Just as a way to think about it, you can actually consider it a partial dislocation. They range anywhere from mild to pretty darn severe. Knees, shoulders, ankles are kind of those really vulnerable. After the injury, the difference is that uh, the alignment kind of goes back to normal in comparison to with a legitimate dislocation. Sprains usually don't involve deformity. Your joint mobility is going to be limited by the pain, but not because there's an actual issue with the joint itself. Signs and symptoms, the patient is unwilling to utilize that limb. They exhibit guarding, swelling, and ecchymosis, like what's seen here on your screen. And then instability of the joint tends to stretch a little bit more than it should. It's really hard to tell the difference between a non-displaced fracture and a sprain, so make sure that you document the mechanism of injury very well and treat both adequately. A strain, also known as a pulled muscle, is a stretching or tearing of the muscle, which causes pain, swelling, and bruising of the area. It occurs because of an abnormal contraction or from excessive stretching. Strains may range from just a minute separation to a complete rupture, but you don't have any ligament or joint damage that occurs. There's often very little deformity, if any at all, and there's just minor swelling, so it's kind of hard to tell. Some patients may complain of like increased pain with passive movement, but most patients just have that extreme point tenderness where that actual tear is. Amputation is when an extremity or piece of the body is completely separated from the rest of the body. The injury ends up damaging pretty much every aspect of the musculoskeletal system, from bone to ligament to muscle, depends on what has been amputated. Complications of orthopedic injuries, a lot of them are not going to be life-threatening, but like we talked about earlier, there is a chance for a lot of systemic changes that can cause long-term negative effects on the patient. The likelihood of having a complication is often related to the strength of the force that actually caused the injury's location, and then the patient's overall health. What we can do if we prevent contamination following an open fracture, that can assist the patient in perhaps not getting an infection. So brush away any obvious debris surrounding the open fracture before actually putting the bandage on. We're not letting anything get inside. We're not probing the wound to make sure that there's no shrapnel or pieces of whatever. Just kind of nice and gently brushing stuff away so that if it's not already embedded, it doesn't become embedded. Long-term disability is one of those huge consequences that can happen from orthopedic injuries. We want to reduce this risk by preventing further injury, reducing the risk of wound infection, minimizing the pain using cold and analgesia. Now, as BLS providers, you don't have the opportunity to use medications, but we do have cold packs. You can um, position the injured limb in a spot that relieves pain. You can splint appropriately. You can provide support. So there are things that you can do, and then making sure that a patient gets to the appropriate medical facility for definitive care. Assessing the severity, the golden period or the golden hour is critical for life and preserving limb viability. If you have an extremity that doesn't have full circulation and you end up with prolonged hypoperfusion, it can cause significant issues, especially long term. Any suspected open fracture or vascular injury is considered a critical emergency. However, most injuries are not critical, they just look pretty gruesome. There's a grading system in your book, Table 31.1, that helps you identify those critical injuries. For patient assessment, always look at the big picture. You want to look at the overall complexity of the situation rather than getting caught up on some of those non-life threatening, though quite traumatic injuries. For your scene size up, you'll start with scene safety, of course. Like everything else, make sure that you take proper precaution because oftentimes with traumatic injuries, especially with our orthopedics, there's going to be blood. Um, Consider the possibility that there may be hidden bleeding and you may not see it. It's not going to be as obvious, I would say, as abdominal bleeding. Um, if you have a significant mechanism to the torso or the abdomen, you kind of are just going to take a guess that something is ruptured in there and the patient is bleeding. If they didn't and they're still dropping their pressures, then you can tell that something is bleeding, but trying to find it can be pretty difficult. Mechanism of injury, look for any indicator of the MOI, primary injuries that occur as a result of the mechanism, but there also may be secondary injuries that occur because of what happens next. So you break your arm, you have compromised circulation, having those tissues around the area getting ischemic, that's your secondary. For your primary assessment, life threats first and foremost, looking for bleeding that could potentially cause the patient to exsanguinate, looking at the patient's overall general impression, treating the patient according to his or her level of consciousness, addressing significant internal or external bleeding, ask the patient about their chief complaint, administering high flow oxygen when necessary, asking more questions about the mechanism. If there's significant trauma and multi-body systems are affected, truly your musculoskeletal are probably going to be lower on that priority list. Scene time shouldn't be wasted on extended musculoskeletal assessment or splinting. Oftentimes, minor splinting is not going to be part of your primary assessment. That can be done en route. Circulation, you want to determine if the patient has a pulse, and then are they perfusing adequately. If the skin is pale, cool, clammy, Your cap refill time is slow. Make sure that you go ahead and treat for shock. And then try and maintain a normal body temperature. Just like with everything else, we're going to go ahead and cover them up. Your transport decision. If the patient has a problem with A, B, or C, we know that we're doing a priority transport. Um, when you decide to do a rapid transport, you can just utilize the backboard as your quote unquote splint because it's considered a full body splint. You don't need to splint each individual extremity by itself. Just putting the patient on the backboard is going to restrict movement to any of those injuries. Um, for like open fractures, those wounds are going to bleed, but oftentimes they're not going to bleed significantly. You can bandage the extremity pretty quickly to try and control some bleeding. You don't want to restrict circulation distally. So if you quickly wrap a bandage around a wound, make sure that you come back and assess that to make sure that you didn't end up causing a distal pulse problem. If you can't control it, you can always throw on a tourniquet very quickly. For your history, you want to obtain just your normal history, your sample history. Oftentimes with our trauma patients, we don't do OPQRST. Pretty much only your ABCs are going to require immediate attention, and there's going to be potential for several different issues. So it's just talking about pain. They're like, well, what pain? The pain in my chest, the pain in my back, the pain in my leg. It's often pretty confusing for them. However, if the patient's mechanism is unclear, the patient's relatively stable, the details of the injury are really unclear, then you can use OPQRST. Typically not going to work with multi-system trauma, but with isolated, you might get a little bit more information. For your physical examination, if the patient has significant trauma, it's often likely that it's going to affect multiple systems. So you want to go ahead and look over the entire body. You'll start with the head, work systematically towards the feet, looking for any sort of DCAT BTLS. And you want to identify hidden and or life-threatening injuries and try and get those under control. If you don't find any external signs of injury, then you're going to go through movement, making sure that your patient can actually move all of their limbs. If that causes any pain, then we're not going to have them continue. When lacerations are present in an extremity, just always consider the possibility of an open fracture. An injury or deformity of the bone may be associated with vessel or nerve injury, so you may not be able to get a really good assessment. You want to continue to check neurovascular function in that limb every 5 to 10 minutes just to make sure that they still have feeling, that they still have pulses, motor function, and sensation. You always check CMS or PMS, whatever you want to refer to it as, before and after splinting. And then examining of a limb should include the 6 Ps, which are pain, paralysis, paresthesia. Paresthesia is that pins and needles feeling, pulselessness, pallor, and pressure. If they have any of those, then that's a pretty serious issue and you need to fix that or transport very quickly if you can't. Vital signs, you want to get a good baseline vital signs. That helps you determine whether your patient's condition is improving or getting worse because of those trends. It's nice to get a set sooner rather than later so that you can easily identify those trends. And we'll carry on in the next one.